Hi, I'm Dr. David Short, ear, nose, and throat doctor. Medical term is an otolaryngologist. So the question was asked is, what does an ENT do? An ear, nose, and throat doctor takes problems that are concerned with the head and neck, which would involve the ears, the nose, the throat, facial structures, and the neck. Sometimes some of the disease states that can be associated with those would be infections of the ear, which would be the outer ear, typically known as a swimmer's ear, or a middle ear, or there's fluid behind the eardrum with associated hearing loss, sometimes with some ringing in the ear, and of course the inner ear, which now involves balance disorders. Nasal cavity problems could include nasal congestion, nasal drainage, nasal polyps, sinusitis. Throat conditions would be tonsillitis, oral membrane tumors, laryngeal problems, hoarseness, and of course throat cancer. And of course the neck with neck masses or salivary gland issues. Facial structures, sometimes when people have cancer of the skin, especially the head and neck, we deal with that as well. So the surgical procedures that we do, it varies significantly on the problem, of course. The most common one would be a tonsillectomy and an adenoidectomy. That's probably our most common surgical procedure. We do a lot of rhinology. Rhinology would include disease of the nasal cavity. We do a significant amount of sinus surgery, correction of nasal airway obstructions from a deviated nasal septum, nasal fractures, repair of the external bony pyramid of the nose. We also do a significant amount of laryngeal work for hoarseness, for throat tumors, for polyps of the vocal cords. Of course, oral cavity tumors are also seen frequently, and we do a significant amount of that. And lastly, we do a fair amount of skin surgery for basal cell carcinoma or squamous cell carcinoma, melanoma of the head and neck. Typically, when somebody presents to our clinic as a specialist, they probably have been treated by their family doctor. So they ask, when do I need surgery? Well, it depends on the individual, of course. But if the family doctor or the pediatrician or the internist has tried multiple medical protocols to improve their medical condition, say it's an ear that just does not want to get better with medication, we definitely can try some surgical interventions. Or if it's the nose, sinusitis just will not clear with medications, we do a workup. We'll work up with usually a CAT scan of the sinuses. Definitely have to have a good ear, nose, and throat examination, which includes endoscopy, which is done in the clinic. We will do a scope up in the nasal cavity into the throat as needed to try to identify the disease state. And if I cannot, or an otolaryngologist cannot control the symptoms with medications, then surgery is an option. It's always an option. Very rare cases that we have for sure surgery, and those would include maybe a tumor, a mass, something that looks very suspicious that might cause the patient more problems if left alone. So that's a very common question that we get in our practices. Do I need to be referred by my doctor? Well, typically when we see patients, they are being referred by another physician because they've been treated for that problem. Typically they've failed medical therapy and of course are now seeking the next step for treatment. But no, patients can self-referral also. The only limitation would be is some insurance companies, not many, but some will require the family doctor to make the referral. But I would say that's a small percentage of our patients. Most people will call and say, I've had this problem for a while. Can you look at me? And of course, even if it's not being treated by the family doctor or internist, we actually can take a patient that has never been seen by anybody else for that problem. And lastly, we actually also see a lot of patients from the emergency room. They'll see patients in the emergency room for a problem, and they'll call and say, I was in the emergency room, they told me to follow up with you, and we do see a significant amount of patients from that source. Yeah, that's actually, we're seeing some of that already. I know here it is still considered winter. I think spring comes in a few weeks from now. And actually, we're already seeing some of our patients come in with allergy symptoms. The most common symptoms that people come in with, and more classic that everybody knows, is a runny nose or sneezing or itchy eyes or itchy skin. Very common. But sometimes allergies will mask themselves as other disease states. A very common one that I see is headaches. Patients will come in with headaches and nothing's causing the headaches except an allergic response. And that's how the body's manifesting that allergy with a headache. So allergy symptoms can vary from the classics to kind of hidden at times. There's other allergies like food allergies that are also a very common thing. But as we get into the season, the most common one is to rinse your nose. We tell our patients, try to get rid of that allergen. If you can avoid it, great. You know, if you're allergic to cats, don't be around cats. Or if you're allergic to grasses or trees or whatever, try to avoid that allergen. If you cannot, then you start treating those symptoms. Most commonly, people will use antihistamines, most common allergen medication that's out there. Sometimes they add decongestants. Nasal inhaled steroids like Flonase is a common one, but saline. I tell my patients throughout the year to rinse their nose with nasal saline. Common thing. If you can rinse out the allergen, usually a lot of the symptoms will abate. If they do not abate and you've done all those things and you continue to have symptoms, then allergy testing would be the next step with that. You know, our population is getting older, so people ask, well, what kind of symptoms do the geriatric patient have that's not seen with younger people? Well, first of all, as we age, there's more wear and tear on the body, and more wear and tear on the ear, nose, and throat region with formation of moisture. The most common thing that I see in the nasal cavity with my geriatric patients is dryness. As you dry out the mucous membranes, inflammatory changes occur intranasally that causes the tissues to swell and block. And as they block, sometimes sinusitis occurs, or they can't breathe, or they don't get enough oxygen through the nasal cavity, so they're mouth breathing. Other things, of course, is hearing. Very common as we age, again, to start losing our senses. Some of the things that we lose as we get older is smell, taste, vision, and of course hearing. And hearing is a very common one that we see. We do a full spectrum of audiology. We have a full-time audiologist that's also a physician, doctor, that does audiology. And we do a full spectrum of hearing aids, full spectrum of ear diseases, whether it's outer ear, middle ear, or inner ear. The last thing we see a lot of elderly patients is their voice. As they start getting older, their voice also starts to change. They either start getting hoarser or they start getting lighter. On rare occasions, it's due to some abnormal finding in the larynx, but typically just an aging voice. So, and that's actually common with kids. You know, when they come to see me, they're very afraid of the doctor. And I don't blame them. They probably have had some experiences where they've had shots, and they always think that all doctors will do the same thing. So people ask, what are you going to do to me? Well, the first thing we're going to do is we're going to get a good history. Our nursing staff will be asking questions on your problem. After that's completed, I do review the history if I'm the nurse. We'll come in and do a preliminary go through of the history, and then we do a full ear, nose, and throat examination. Whether you come in with an earache, or a nose ache, or a throat ache, you get a full ear, nose, and throat examination. I will look at both ears, look at the nostril, both intranasally, at the mouth, feel your neck. If there's a question with an exam that prompts me to do some other things like endoscopy, we do a lot of endoscopic procedures in the office, which means a little scope in the nasal cavity, a little scope in the back of the throat to look out for other things. Very commonly with our smoking population, we look at the voice box. Many patients that come in with a smoking history, whether they're there for a throat problem, we will do an endoscopic examination. Throughout our practice in our lifetime, we have found many patients with throat symptoms like a tumor or a growth or cancer that never had symptoms of hoarseness. So we want to catch everything very early. Other things you can experience if you're having a hearing loss is you probably will get a hearing test or at least some audiological test to see what's causing your hearing loss. And very rarely do we have to do that surgical procedures in the office, although that focus of the practice is changing for more office procedures versus less surgical procedures. So we're doing more office procedures. Office procedures that are being done now is for correcting nasal airway obstructions. What we used to do under anesthesia, these are being done awake with great results. Some of the surgical procedures that we do in our practice would be, of course, ear surgery, tubes. We do those in the office with adults. Children, we put them to sleep. Nasal surgery, nasal airway obstruction, a condition called nasal valve collapse is where the tissues of the nose are starting to shut down. Those can be done in the office where they used to be in the operating room. Very good results. A lot of the throat surgeries that we can do, they can be done in the office now instead of going to surgery. So the focus of ENT is to do less invasive surgery with better results. I can imagine if I was a patient and I was coming to see an ear, nose, and throat doctor with a condition, first of all, I'm very worried. Sometimes they're scared there's something bad is going on, especially if it's in their throat. Many patients come and say, I know I have cancer. That's a lot of times, that's the first thing they tell me. I try to ease their concern by telling them that's a very uncommon thing, but we will look. And when you leave today, we will know what's going on, or at the very least, we'll do some studies to find out what's going on. And putting a scope in somebody's nose, putting a scope in somebody's throat is a scary proposition. But we do prepare the nasal cavity very well. We do numb it. We do actually get the patient enough time to allow that anesthetic to take effect, so the discomfort is very small. We're putting scopes in 2-year-olds, and they do well. Yeah, they're scared, but there's really minimal to no discomfort if it's done properly. If you do have an ear, nose, and throat symptom, and this is more commonly seen in my male patients, sometimes they wait too long. Sometimes patients will say, it'll go away. And some things do not go away. Some things actually get worse, especially if it's related to the throat. I've seen patients that have waited, and not just the men, but commonly it's my men, that wait a little too late. When they come in, they're very, very hoarse. And if they have a disease state, it's very advanced. That's why when patients come in and we have a suspicion that they smoke or anything, we look down there. We want to catch things early, because we catch things early, those can be corrected with minimal discomfort. When they get advanced, it gets a lot harder.